Good afternoon. My name is Ho-Cheol Jang from Department of Hematology at Jeonnam National University Hwasun Hospital. It is my honor to give you the presentation as the Young Investigators Award at Hwasun Biomedical Workshop. Today I will talk about clinical use of bioinformatics in hematologic disease. In this talk, I will briefly introduce what next-generation sequencing is, and then I will introduce 3 topics of my research of this year. Finally, I will discuss how this approach can support the precision medicine. As all you know, traditional Sanger sequencing is very accurate but cannot read long DNA sequences. NGS, on the other hand, can read millions of DNA fragments in parallel. Because of this, NGS gives us more deeper coverage, higher sensitivity, and broader view of genome and transcriptomics. Today, NGS is not limited to DNA sequencing. Using different NGS-based methods, we can measure gene expression, DNA methylation, transcription factor binding, and 3-dimensional chromatin structures. How does this connect it to personalized medicine? NGS let us see for each patient the mutation profile, clonal architecture, and specific gene expression pattern. So, NGS help us move toward tailored treatment based on the biology of each patient. There are 3 types of DNA sequencing: genome sequencing, exome sequencing, and targeted gene sequencing. Genome sequencing can cover all genes, whereas exome sequencing covers only entire exome. Targeted gene sequencing covers only predefined gene sets. These methods have different accuracy, time, and cost and depth. Our first talk is DLBCL and targeted gene sequencing. Our question was targeted gene sequencing can provide more information beyond our current classification. We performed targeted gene sequencing from tumor sample patients who diagnosis the DLBCL. We can see the distribution of the non-gene mutation from our Manhattan plot in figure 1, and we performed random forest analysis to identify genes that most strongly associate with overall survival and progression-free survival. We used this important gene to perform principal component analysis and clustering, and we can find specific clusters. Even within the same conventional subtype, there were substantial heterogeneity. This distinct cluster, we called it cluster 2, showed inferior progression-free survival, and this cluster was enriched for a specific combination of high-VAF genes. So this targeted gene sequencing can help us identify high-risk patients, and these patients need more intensive treatment or alternative strategies from the beginning. Our second talk is chronic lymphocytic leukemia using whole exome sequencing. Here, our focus mainly on how do exome-wide mutation pattern change during the treatment, and do this pattern differ according to the treatment responses. This is the result of whole exome sequencing. Some patients experienced rapid disease progression and did not complete the 6th cycle of treatment, and depicted here as NE, not evaluated. And some patients who had relapsed tend to more scattered and heterogeneous distribution in PCA. This trend also observed in 3 months after treatment termination. Patients with PD showed scattered and heterogeneous distribution, whereas who maintained CR showed clustered and homogeneous distribution. This trend is observed in trajectory analysis. In patients with CR, the PSA point moved into the more compact region, but in patients who developed progressive disease, the trajectory were more complicated and randomly distributed in PCA. So the baseline exon pattern at diagnosis may already have the future risk, even if the initial response seems good. So whole exome sequencing can visualize how the diploid clone expand or shrink with the treatment. Let's move on to our third talk, the single-cell RNA sequencing. This slide will show the pipeline of RNA sequencing. Our third talk also focused on the CLL, but in this work, I focused on the T cell. So my question was how the T cell state differ between the responder and non-responder in the chemotherapy, especially in the memory or effector T cell subtypes. And this is the reanalysis from the publicly open data in CLL from the previous work. So I performed the standard single cell analysis, clustering the all immune cell and identify the major cell type and zoom in to the cell type of interest, to me the T cell. I mainly focus on the CD8 T cell, CD8 effector T cell, which already encountered the antigen and have the anti-tumor activity. At the time point of relapse or complete responses show a different transcriptomic profile as well as the different transcriptional factor activity. Patients who reached CR turn off the overall T cell activation related marker or T cell or transcription factors, but who do not reach the CR or relapse persisting the disease show activated the T cell signatures. This data included the good responder as well as non-responder for the chemotherapy. I focus on the time point of diagnosis and wonder what makes the chemotherapy response different. In patients who reached complete response show higher T cell activation capacity at baseline, whereas who were refractory to the disease show a more exhausted like T cell feature. So after successful chemotherapy, both exhaustion and cytotoxic marker tend to decrease, which likely reflect the normal contraction of the immune responses. And also at the time point of diagnosis, the T cell activity we measure by transcription factor can predict the treatment responses. In this talk, I introduced the clinical use of NGS in hematologic disease. So NGS can provide the in-depth analysis of the disease, can redefine the high-risk patient, and also can explain the disease course as well as the dynamic change in specific cell population. So I think the NGS will become more central tool in hematologic malignancies. Thanks for your attention.